Welcome to my YouTube channel. Today we're going to talk about TB management. So I'm just going to start with treatment of latent TB infection. So if you don't know what is latent TB infection, I would recommend you go and watch my video about latent TB infection and all what about latent TB infection is. So just to brief you, just to give you a snip end of what latent TB infection is. Uh, Latent TB infection is when you have been infected by TB, that is Mycobacterium tuberculosis, and then your immune system has controlled the infection. You have three phases when you're infected by TB. It's either your immune controls the infection, or your immune clears the infection, or you get active TB. So when you're at latent infection, then your immune has controlled the infection. So we have shorter regimens. Rifampin based are always preferred. So you can have daily rifampin for 4 months, or you can have that is demarcated as 4R, or you can have 3HP, where you have once weekly isoniazid plus once weekly rifampicin for 3 months, or where you have 3HR, where you have daily isoniazid plus rifampin for 3 months. Or you could just do the longer periods where you have a daily isoniazid for 9 months, and we call that 9H. So monitoring for just the drugs we've talked about, adverse effects of isoniazid and rifampin include hepatotoxicity, but isoniazid is on a higher level of hepatotoxicity compared to rifampicin. So rifampicin also causes rash and thrombocytopenia. So you discontinue this drug in case the patient is asymptomatic and has serum transaminases of greater than 3 upper normal limits, or the patient asymptomatic and serum transaminases are greater than 5 upper normal limits. So treatment of now the TB disease where the immune does not contain the infection and you get the TB includes the first, this is the traditional method and still used up to today, where you have the first, where you have 4 drugs, that is the right, that is rifampin, isoniazid, pyrazinamide, and ethambutol. So this, the traditional regimen, you go for 2 intensive phase where you do all of the 4 drugs, and the continuation phase where you just do isoniazid and rifampin. However, you have a shorter regimen that is rifampicin and moxifloxacin, which is not actually recommended. However, if you go that way, you will do intensive phase of 8 weeks and a continuation phase of 9 weeks. So what to consider during the intensive phase? We said the intensive phase for the transitional regimen, that is the right, you do it for two weeks where you do the 4 drugs. So if pyrazinamide must be included in terms where pyrazinamide is actually hepatotoxic. Pyrazinamide causes decreased excretion of uric acid from the kidneys, which could be contraindicated in terms of gout or pregnancy, where it must be included. Then isoniazid, rifampin, and ethambutol will be administered for 2 months, and then you will continue with the continuation phase for extended period of 7 months, and the total duration will be 9 months. I hope you have understood. So where you have to not do pyrazinamide, which is actually the drug with most hepatotoxicity, and you will just have to do isoniazid, rifampin, and the ethambutol, the rest of the 3 drugs for 2 months, and then you continue now with the continuation phase where you do isoniazid and rifampin for 7 months and a total of 9 months. So when do you expect clinical improvement? So you expect clinical improvement in terms of signs and symptoms within 2 weeks, after starting appropriate treatment. Lack of clinical improvement should promote further evaluation. So how do you assess the completion of the intensive phase? You always have to do a clinical assessment. Do you still have symptoms? Do you still have these signs? Then later you do a smear, acid fast base smear. You do culture, followed obviously by drug susceptibility if your cultures are positive. So consideration in the continuation phase, the consideration in the continuation phase. This is just from now the intensive phase. After the intensive phase, we say that you have to assess through clinical symptoms. You have to assess through the smear. You also have to assess through culture. As do we have culture conversion? And then now, if there's positive culture, you do drug susceptibility. And just as this, for the approach is guided by what we have just talked about, that is the smear. We have said that we'll do them at 2 months, or if you had presence of cavitation on a chest X-ray at the time of initiation of treatment. So let's just go slowly. This slide is intensive and it has a lot of content in it. So we'll just read and just I'll explain slowly as we go on. So sputum should be obtained for the smear and the culture at monthly intervals until you have 2 consecutive culture which are negative. Understood? That's just a phrase. Now we go on dissect the rest of the information. So a positive sputum culture at 2 months, you'll have to do drug susceptibility testing, and if it is a drug resistant TB, you treat as drug resistant TB. I hope you have understood that statement. So we have said at the end of the intensive phase, that is 2 months, you do a culture. If your culture is positive, then you do a drug susceptibility testing. Then if your drug susceptibility testing shows that you have drug resistant TB, you treat as drug resistant TB, which we will talk more about. And then next, patients with both delayed culture conversion beyond 2 months and cavitation at the initial chest radiograph, continuation phase should be continued for 7 months, a total duration of 9 months. So let me explain what is delayed culture conversion. Delayed culture conversion is where when you are starting the treatment, where you did culture, the culture was positive. Later, approximately at 2 months, your culture at an ideal setting with appropriate treatment, you should not have a culture which is negative. So you should have a culture which is negative. However, when you have delayed sputum culture conversion from positive to negative, that is beyond 2 months, plus at the initial when the patient was coming and you did a chest X-ray and you saw cavitation on a chest X-ray, then you'll have to do continuation phase for 7 months, and now you'll have a total of 9 months. I hope that statement is understood. Next, so this is both where you have delayed and also you have cavitation on the chest X-ray. Patients with either delayed sputum conversion culture, which I've said this is beyond 2 months, or cavitation on the initial chest radiograph, a continuation of 4 months, that is total of 6 months, is acceptable, which is the normal. Then patients with positive sputum culture for 3 months, which I hope you are getting. 3 months is too long. Further investigation, including drug susceptibility testing, and you review for causes of treatment failure is warranted. For example, the patient GI has problem leading to malabsorption, the patient is not adherent to the drugs, among other factors. So for patients with positive sputum culture, after 4 months of anti-TB treatment, then that we call, you presume it as treatment failure. I hope you have really understood up to that point. The slides are very self-explanatory. You just need to stay and read if you have not understood. So next is when can I shorten this continuation phase? Continuation phase may be shortened to 2 months. The ideal is 4 months. Total treatment for the TB will be 4 months. In patients without HIV infection, with evidence of TB infection but negative sputum cultures, with symptomatic or radiographic improvement in absence of alternative diagnosis. However, most guidelines will recommend for you to finish the treatment, that is 6 months, 2 of intensive, 4 of consolidation. Treatment completion, that is completion of treatment, is determined by the duration and more so the total number of doses administered. That is very key. So in the next slides, we are going to talk more about these drugs. We'll start with isoniazid. Isoniazid causes elevation of LFTs. That causes hepatotoxicity. Isoniazid also interrupts the inhibition of cytochrome 450, meaning drugs that are metabolized by this enzyme will be affected. Less common, it also causes drug-induced lupus. In addition, this is very important, vitamin B6 causes peripheral neuropathy. That is why we give pyridoxine as a supplement when giving isoniazid. In addition to high doses of isoniazid causes CNS toxicity, which precipitation of the this CNS toxicity, which causes or lowers the threshold of seizures, and these seizures are refractory to benzodiazepine treatment. This is because isoniazid, which inhibits vitamin B6 or causes vitamin B6 deficiency, and it is very essential in the synthesis of GABA. Next is pyrazinamide. It's a very essential molecule which is highest hepatotoxicity, causes hyperuricemia. This is because it inhibits secretion of uric acid, a drug for photosensitivity. The next is ethambutol. Ethambutol, just remember red and green, which causes optic neuritis, which is reversible red-green color blindness. Rifampin, if you forget about anything, it causes orange coloration of bodily fluids. In addition, it also cytochrome P450 induction, which it will have to influence diets like oral contraceptives, among others. And it also causes transient asymptomatic elevation of bilis, causing clinical hepatitis with a cholestatic picture. In addition to that, it also causes thrombocytopenia, which is immune mediated. So drug-induced hepatotoxicity, as you mentioned, is adverse effect of isoniazid, rifampin, pyrazinamide. So it is so when hepatotoxicity attributed to anti-TB should be promptly discontinued of all hepatotoxic drug if the following: if the patient is asymptomatic, then serum you discontinue when serum if the patient is symptomatic, then you discontinue when the transaminases are more than 3. If the patient is asymptomatic, then you discontinue when serum transaminases are greater than 5, and then you also discontinue if the serum bilis are greater than 3, as you have said. And as I've said, as serum transaminases are more than 5, the upper limit. So once now these elements or these features return, that is the serum AST, LT, and the bilirubin return to baseline, or they fall to less than twice the normal, then the potential of the drugs can be restarted once at a time. And then when you're restarting the drugs, when you restart the drug, you don't just restart all of them at once. You just start one after the other. So we'll start with monoresistant TB. Monoresistant TB is where you have resistance to one of the drugs in TB. So for example, you have resistance to isoniazid, you have resistance to pyrazinamide, among others. So when you have isoniazid monoresistant, so just to brief you, when you are watching this video, you must be knowing how we treat TB. You must be knowing the first drug we use to treat TB and some of the second line drugs. So the first line drug is isoniazid, rifampin, ethambutol, and pyrazinamide. So the second line drug include mostly fluoroquinolone, amikacin, among others. So isoniazid monoresistance, if you have isoniazid monoresistance, you can have two options. So you give patients daily rifampin, ethambutol, pyrazinamide plus a fluoroquinolone. So in short, you'll just have replaced the isoniazid with a fluoroquinolone. That could be levofloxacin or more. This is more moxifloxacin for 6 months or 4 months after culture conversion. So I hope we are all together with that. Option 2 is if the patient does not tolerate pyrazinamide, which is highly hepatotoxic and also hyperuricemic, then a regimen consisting of rifampin, ethambutol, and a fluoroquinolone could be used for 9 to 12 months. So when a patient is resistant to rifampin alone, should be treated as multi-drug resistant. This is because rifampin resistance is a surrogate for multi-drug resistant, because on itself it's very rare. So the next drug is pyrazinamide resistance. Patients with monoresistance are treated with isoniazid and rifampin for 9 months. And most of these isolates of monoresistance reflect on Mycobacterium bovis, which is the reservoir is cow. And how do we get it? By ingestion of contaminated cow milk. So monoresistant ethambutol or streptomycin, or maybe second line, are of little clinical significance, and patients with disease caused by this isolate may be treated just with drug susceptibility TB, that is the 4. I hope you are okay. So we've said if patient has isoniazid monoresistance, just remove the isoniazid and replace it with levofloxacin, and then you can go for 6 months. And then if you have for 6 months or 4 months after culture conversion. Culture conversion is where you had positive culture and now they are negative. And option 2, if the patient cannot tolerate pyrazinamide, then you replace it with you just remove it and continue the drug the regimen for 9 to 12 weeks. Rifampin, you said we treat it as multi-drug resistant. We're going to talk more about that. Pyrazinamide, we said you just monoresistant, we just treat it with isoniazid and rifampin for 9 months. Next, treatment for polyresistant TB. What is polyresistant TB? Polyresistant TB refers to TB caused by an isolate of Mycobacterium tuberculosis that is resistant to more than one of anti-TB agents. Isolates may be resistant to either isoniazid or rifampin, but not both. So when you have resistance to rifampin and isoniazid, it may be some other drug that is multi-resistant TB, not both. So you can have isoniazid and ethambutol, or you have rifampin or ethambutol, or rifampin and pyrazinamide, but not isoniazid and rifampin at the same time. So patient with TB resistant to isoniazid and ethambutol. Now we are going one by one, and of which we said rifampin we treat it as multi-drug resistant. So we're just going to deal with isoniazid plus other drug. So patients with isoniazid and ethambutol should be treated with rifampin, pyrazinamide, and so just remove the 2 of the drugs, and then you add fluoroquinolone, and you lengthen the period, that is 6 to 9 months. Patients with isoniazid and pyrazinamide should be treated with rifampin, ethambutol, fluoroquinolone, that would be either levofloxacin or moxifloxacin for 9 to 12 months. So when you have resistance to pyrazinamide, you just remove the pyrazinamide, and then you just add fluoroquinolone, and then you lengthen the period to 9 to 12 months. Patients with resistance to isoniazid, ethambutol, pyrazinamide should be treated with rifampin, fluoroquinolone, and 1 or 2 other additional or oral agents to which isolate is susceptible to, which include linezolid, clofazimine, or use of bedaquiline, which I'm going to talk more about. So if a patient is resistant to the 3 drugs, then you just do rifampin, fluoroquinolone, or 1 or 2 of the drugs that you have mentioned above, and then you do them for 9 to 12 months. And then lastly, we are going to treat treatment of multi-drug resistant TB or resistance TB, or extremely drug resistant TB or drug resistant TB. So all of this, in addition to rifampin monoresistant TB, which is said is rare. So if you get rifampin monoresistant TB, you treat it as multi-drug drug resistant TB. So there are 2 regimens where you have abbreviated regimens that run from 6 to 12 months, or you have longer individualized regimens that all of them are oral regimens, that is 18 months. So the abbreviated ones would be PBL or PBLMN, that we're going to talk about more. That is, you treat the patient with bedaquiline, protamide, and linezolid. That is the first drug. This is the more preferred drug, or that is the PB and linezolid. And then, or you treat the patient with bedaquiline, protamide, linezolid, and moxifloxacin. You just had amoxifloxacin. So each you all administer them for 6 months, or alternatively, you could also do dilamide, linezolid, fluoxacin, and pyrazinamide for 9 months if you don't have bedaquiline-based regimens. Thank you.